Good afternoon or good morning, depending on where you are, everyone, and welcome to the Stem Cell Transplant chapter. My name is Audrey Burton-Bethke, and I will start with just a couple intro slides to get started. Always takes a minute to make sure I'm in the right place. I'm grateful for your support and your participation here. For those of you who don't know me, again, my name is Audrey and I am the Myeloma Crowd Community Manager. The Stem Cell Transplant chapter is a part of our Myeloma Crowd Community by HealthTree program, and we're really excited to meet with you today. Today's session will be recorded. It looks a little bit different from what we're used to, a Google Meet. We're doing a Zoom webinar this month. And the recording, along with the slides that I share, will be sent to all registrants within 48 hours after the event has concluded. A special thanks to our sponsors, without whom this would not be possible: Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnologies, Sanofi Oncopeptides, Karyopharm Therapeutics, and Takeda Oncology. The topic today will be the role of vaccinations, past, present, and future. And we talked a little bit about vaccinations last month. And as we considered talking about vaccinations this month, I realized that talking about vaccinations in a stem cell transplant setting can be difficult because every treating physician seems to do it a different way. Every stem cell transplant facility recommend something different, which is why there doesn't seem to be a right or a wrong answer when it comes to that. The vaccination schedule varies significantly, as well as what vaccinations are delivered in what order. So it didn't seem, I'll say, appropriate to have somebody come speak to us about their opinion in what vaccinations should come in what order, but rather we decided to focus on what would the role of vaccines be post-transplant. What are the different kinds of vaccines that are out there? And then in the future, looking forward, what is the role of vaccinations and immunotherapy within the myeloma arsenal? So we invited Dr. Avigan to speak to us. He is going to be the one to speak to our group about the critical role of vaccines, and we are really excited for his presentation today. It's my pleasure to introduce him to you. Dr. David Avigan is the Chief of Division of Hematology and Hematologic Malignancies at Beth-Israel Deaconess Medical Center in Boston, Massachusetts, and is a professor of medicine at Harvard Medical School. Also, if you can hear the construction in the background, I didn't know that was happening today, but they decided to do some construction in our office, so forgive me if you can hear that. Dr. Avigan's clinical interests include multiple myeloma, lymphoma, leukemia, cellular therapy, CAR T-cell therapy, immunotherapy, and all bone marrow transplant services. His board certifications include the American Board of Internal Medicine, the American Board of Internal Medicine Hematology, and the American Board of Internal Medicine Medical Oncology. Dr. Avigan graduated from the Yale University School of Medicine, completed his residency at Columbia Presbyterian Medical Center, a fellowship at the Memorial Sloan Kettering Cancer Center. Dr. Avigan is fluent in English, Hebrew, and Spanish. So Dr. Avigan, we're really excited to hear what you have to discuss with us today. And the time is now yours. Thank you for being here.
Great, thank you so much for having me. And if I do lose connection here, because that just happened as you were speaking, I will come back on. So hopefully there won't be any drama. And I do have to apologize because I think that picture you have of me is probably a little bit dated, as you can tell from the gray hairs that have been growing more recently. So, thank you for inviting me to talk about this really, of course, very pertinent topic. And I think vaccinations in general, of course, are very much on people's minds in the context of the COVID pandemic and trying to understand their role. And it has certainly highlighted both the power and potency of this approach, but also the potential issues, and trying to think about how this might work, not just in terms of protection from infection, which is of course part of what we're going to be discussing, but also thinking what our focus has been research-wise is how these might be developed as anti-myeloma therapies and as part of the arsenal in treating cancer with immune therapy. So I think we're going to, instead of going through, as you said, exact recommendations, which there is some resources that do this very well, including the NCCN, which provides guidelines about recommended vaccinations, we'll talk a little bit more conceptually about what is the reason we think about vaccines in these settings in myeloma patients in general, in the transplant period. What are the issues that we might think a little bit about, even in the context of COVID, and then talk in a bit more depth about the role of vaccines as immunotherapy and how they may integrate with some of the other things that we know about, like CAR T cells and other things that are being developed. So, I think that one of the basic questions is understanding a bit how the immune system works and why vaccines play an important role in protecting against infection. And so we know that there are two really basic parts to our immune system, what we call the humoral immune system, which is the part of our immune system that makes antibodies, and antibodies float around in the blood and they bind to potential foreign invaders such as bacteria and try to help clear them and also sort of tag those foreign invaders as something that should be eliminated by other, for instance, parts of the immune system. And then there's a cellular part of the immune system that is often run by T cells and NK cells, and those cells have the ability to sample what's going on inside a cell itself and to potentially then target it and kill it. So for instance, a virus infects cells, it sits inside the cell until it causes that cell to burst. And so it's really the T cells that will sample a cell and say, hey, there's something foreign going on in this cell, something abnormal, something that deserves targeting and being killed. Now, that very important sort of way that we protect ourselves from infection has to be balanced against the immune system not causing runaway trouble, because we have within our immune system the ability to recognize what we would call self or normal antigens that sit inside the body. The immune system is kind of funny. It develops a repertoire of targets that in some ways is arbitrary and random. And so it may have an imprint that would potentially target a normal skin cell or a normal liver cell. And so we have a secondary line of defense against that, which basically causes the immune system to either be stimulated and be activated or to be tolerized or rest down. And so that very delicate balance between the self things or the things that belong within the body and should not be targeted by the immune system is always in operation. We're always sort of dampening down or controlling the immune system so that it doesn't overachieve, it doesn't overattack normal things. And at the same time, we deliver danger signals when there is the presence of an abnormal, let's say, attacker, bacteria, viruses that we wanted to go after. And that balance is sometimes difficult to maintain. And so what we know that when patients, for instance, get an infection, they often get sick and they get fever, they feel crummy, they get muscle aches. Some of those symptoms are not actually caused by the pathogen, but they're caused by the immune system's response to that pathogen that multiplies cells, release certain cytokines or hormones that drive activation, but also can cause side effects. And so this sort of balance between tolerance, recognition of things that don't belong, danger signals that trigger that, but then the reestablishment of tolerance is very important. And it's, it's just a very good example. If patients, for instance, have a viral infection and they may develop a rash, sometimes that rash is not actually caused by the virus, but it's caused by the fact that the immune response against that virus stimulates things, causes danger signals, and that leads to some short-term effect of autoimmunity where you start to target your own skin, and then the body reestablishes sort of that tolerance after that. Now, what are vaccines? I mean, vaccines are basically efforts to educate the immune system to go after certain material. And it, in that way, provides a danger signal. It says, if you see a mumps virus antigen, or if you see this kind of bacteria, pneumococcal bacteria, you should see that as foreign and you should go after it. And the way that that often happens is something is taken from that target, let's say a protein or a peptide, what we call an antigen, something that is from that cell. And now it's introduced with a danger signal. And that danger signal or stimulatory signal is saying, when you see this, don't rest down, activate, make your response, make your antibodies, make your T cell expansion. And so we want that kind of recognition because it will lead to then not only the establishment of a response, but what then happens is the ability to form memory. So we want to have not just a response for the next, 6 months or 3 months or even week, but what we're trying ultimately is for there to be an army of cells, even though they're not active in this moment, but are there essentially preserving immunity by acting as a surveillance system. So when we give vaccines to people as children, what we're trying to do is immunize them, develop their repertoire so that the T cells that recognize tetanus or hepatitis or mumps, those are all being activated and expanded, and then they rest down into a memory state so that if the person ever meets that pathogen again, they have a ready-made group of cells that can re-expand and reactivate. They've already gotten that first signal, that first move towards activation. They've already been what we call primed. And the vaccine helps to do that. Now, if you get the infection and get very sick, you would also develop a memory response. But what we're hoping to do is, without getting sick, we're hoping to make the memory response happen. And so what we often will do is, instead of exposing somebody to the whole virus or the whole sort of bacteria, we're taking pieces of it that you can respond to, putting it in the context of that stimulatory information, and then having the immune system recognize and be ready without the person having to go through the illness. Now, as you can imagine, as people age, some of that protection may wane. And so we know that patients, for instance, as they get older, they may lose immunity to things like chickenpox, for instance, that they might have had as a kid. But when patients develop certain types of cancer, and blood cancers in particular, where the cancer itself tends to be involving the immune system, we sometimes will lose memory against those responses. So we might have been vaccinated as a kid, and that would be protective. But as we develop problems with our immune system, we then lose that protection. So let's talk for a moment about myeloma in a specific way. So myeloma is associated with an erosion of the immune system. And we know this in a couple of different ways. The first simple thing to know is that one of the ways that sometimes patients present with myeloma is that they present with infection. They may have a history of recurring sinus infections. They may have a history of pneumonia. I've even seen patients present with meningitis. They have something going on. And of course, people can get infections in a normal situation as well, but something is going on that's showing the immune system is not working as well. And then when you actually look at the immune system and you analyze it, you see that both parts of that immune system, the part that makes antibodies and the part that provides the T cell protection, the cellular protection, have been affected. So for instance, we often see an elevated antibody level or M protein in myeloma. That's one of the ways we can sort of follow the disease, because the abnormal plasma cell makes that M protein. But if you look at the normal immunoglobulins, the normal antibodies that are sitting side by side with it, they are often decreased in numbers. And as you may know, that some patients don't have an elevated M protein. They may just have an elevated piece of the antibody, the light chain. But if you then look at their normal immunoglobulins, their normal antibodies, they're often suppressed. So you have a loss in them numerically, and the B cells that make those antibodies tend to not work as well. And at the same time, you can see abnormalities in the T cell function also. And some of the repertoire that is there to help protect against infection, activate when we see something, starts to become decreased. Now, it's not the same in everybody. And we know that myeloma can evolve from pre-malignant conditions like MGUS or even smoldering disease. And it does happen that there is often a tracking with that, so that as patients develop more evidence of the myeloma being present and being more prominent, the immune dysfunction tends to follow that. So one of the questions is, well, how do we protect people from that? And you might say, well, should vaccines be readministered? And one of the hard things is that those same cells that would normally make the protection are the ones that respond to the vaccine. So you might say, well, it's great that the vaccines may help us, but are the vaccines going to work in this setting? And the answer is, it of course depends very much on the individual. but they seem to be in many settings at least partially effective. And so we do think about that. So an example is influenza, where we know that patients, the flu does change a little bit each year. And so there is a yearly vaccine offered to deal with those changes. And in general, patients with myeloma should be in the category of people that we give a flu vaccine like we do to anybody who's older. Pneumococcus, which is another type of, in this case, bacteria that can cause pneumonia, is something that we often will give to people as they get older. Again, these are all examples of trying to provide protection as people age. But in myeloma, another example where you would make sure that you're keeping up with those type of vaccines, because there would probably be an increased susceptibility to infection, not just because of age, but also because of this added piece. Now, there is then some unique settings that we think about in myeloma. So for instance, some of the therapies that we use are going to target aspects of the immune system. So we know that proteasome inhibitors like Velcade can suppress the immunity and can, for instance, make people more at risk for things like shingles, which comes from the chickenpox virus. And so we're often very careful about using either suppressive therapies like acyclovir or thinking about vaccines. And the Zoster vaccine is something called Shingrix, which is a recombinant vaccine. Now, why do I say that? One of the ways we sometimes give vaccines is by giving live viruses, but they are attenuated in some way. So as we said, one of the ways to get protection is to actually get sick, get the virus, and then of course, hopefully you're okay. And then you now have your immune system has been primed with all those danger signals to fight against that antigen. Some types of vaccines might be what we call a live attenuated virus, where it's the same virus, but it just has been injured in some way, so it doesn't cause as much really illness, but it still can infect cells. And those we tend to be a little bit more squeamish about, or a little bit more careful when a patient's immune system isn't working well, because the attenuated viruses can cause trouble. So we often are looking for non-live vaccines or recombinant vaccines that are really just about the proteins or the antigens with some kind of stimulatory factor. Now, I know this session has been very much focused on the idea of transplant, because transplant happened to be one of the things that we learned to do somewhat early in the treatment of myeloma that we knew affected the immune system. And what autologous transplant, which is really the main type of transplant we think about for myeloma, is really, as folks may know, a form of giving high doses of chemotherapy and then giving the person's own cells to help them recover. So in that way, it's the person's own immune system that is recovering, but the high doses of chemotherapy themselves can cause an erosion of the immune system, at least transiently. So if you study people over time after transplant, you'll see that some of the function of T cells and B cells don't work as well, particularly for those first 6 months after transplant. It takes them a while to recover. We also noticed that if you look at antibody levels that people have to things they got vaccinated when they were a kid, that some of that stuff starts to disappear or is lost or suppressed. And so that became one of the first settings where we thought about revaccinating people against the things that they had been protected against as kids and may have lost after transplant. I think it's important to say it's not that transplant is unique in this way. There are a lot of therapies that could potentially lower immunity, and myeloma itself lowers immunity, but that's a setting where we've studied it in very careful ways. And many of the childhood vaccines that are relevant here, and they include things like tetanus, pertussis, and diphtheria. They include things like the hepatitis vaccines in people who are at risk for that, meningococcus in people who are at risk for that, pneumococcus. Those standard vaccines, we generally will have a course starting somewhere between 6 and 12 months after the patient has been treated. Now, why wait? You could say, well, the biggest risk is early on when the immune system is working less well, right after the transplant. Well, then you get into the conundrum that we talked about, which is that's a time where the immune system is working less well, but it's also a time where the vaccine is less likely to work because it doesn't have those sort of helpers to respond to it. So the data generally suggests you have to wait a little bit of time. Often that 6 to 12 month period is when people are vaccinated, although there have been some studies looking at it earlier on. Now, I wanted to spend a few minutes talking about COVID, because that's obviously very much on people's minds. And then I think we'll pivot, talk a little bit about cancer vaccines, and then give people a chance to ask questions if I'm I'm allocating the time there correctly. So we know, obviously, we're in the midst of a very difficult pandemic from a virus that most people do not have really intrinsic immunity. It's not that they've seen it before when they were kids, so now when they see it, they have already protection. Most people really are vulnerable to this virus if they haven't seen it before. And the other thing that we saw from the active infections is that the virus itself causes some degree of immune suppression. So it's not entirely clear that everybody who's had the infection now has developed this great memory response. Some people seem to have that, some people less so. But there was a particular concern about people whose immune systems were not working well. And this became a complicated thing that has to do with the physiology of the virus, because viruses make people sick in different ways. One of the ways it makes people sick is by attacking cells directly. The virus causes a lytic response that can cause cells in the respiratory tree to become inflamed and die. And that in and of itself can be dangerous, but also sometimes it's the wave of the immune response afterwards, the body trying to fight it off, that can also cause complications. And we know with this virus, there are complications that aren't just about the direct effects, for instance, on breathing or the lungs, but secondary effects on blood clotting and other things that may have to do with an inflammatory response. So we were, of course, always wanted to be careful with patients with immune deficiencies or underlying conditions that make the immune system not work so well, that they may be more vulnerable to infection, that the infection may progress more rapidly. Although it is always a question, would they have less of that immune response that also causes problems, or how would that affect things? And so there's been studies to try and understand, what do patients, for instance, with cancer or even specific type of cancers do when they, what's the general course with COVID? And the data is not always exactly the same. There have been some studies that show really a real increase in worry, for instance, in myeloma patients, some a little less so. But in general, in aggregate, I would say that cancer patients tend to have a higher risk of complications and even mortality from this virus. And so it's a particular group of patients that we want to be careful about and guard as much as possible. And so that's one of the background when we were thinking about the vaccines. And as people know, that when they were rolling out the vaccines, there was some initial preference both on age, that's a group of patients where the immune system also may not work as well, and based on certain underlying conditions, and cancer being one of them. And I think myeloma being a particular issue for the reasons that we talked about, that it has particular immune deficiencies. Now, of course, that raises the question of, well, how well will the vaccine work? Is this a group of patients that because of the immune deficiency, vaccine may be less effective? And how do you measure that? And the honest truth is that this is something still being worked through and understood. So there's been some studies that suggest that patients with certain underlying deficiencies in their immune system and certain types of malignancies, such as CLL, which is a type of lymphoma or myeloma, that those patients that are known to have some suppression of the immune system tend to not respond as well to the vaccine. And when we say not as well, when they have done studies and looked at what's the height of the antibody level when you give the vaccine, it tends to be lower than if a person didn't have that issue. There's a very important question to say, do those antibodies actually represent protection or not? And I think, or are they sort of correlate, but they're not exactly the same. And because some of the protection may come from the cell-based part of the immune system, what we call T-cell immunity, which is not measured in that way. But we at least think that the antibodies give us some insight into that. So there is definitely the sort of, I think, experience that this is a group of patients that's really important to protect. The vaccine, we hope, provides protection, but that the degree of that protection may be a little bit less reliable. And so that when we think about that, that's an important thing when we're trying to think about next steps. I know there's been a lot of discussion now about boosting vaccines and should that be done. There's been some evidence in certain types of immune suppressed patients that there may be some benefit to that. I think we're still trying to understand and learn, and that may be applied, frankly, to everybody who may have a declining immune response over time. So this is something that's very much being studied, and we are all looking towards, the national organizations to give us guidance about what the next steps in that regard are. I should mention that Not all patients, of course, are the same. There has been a sense that patients with more advanced disease may have more of an effect on the suppression of the immune system, and that patients on certain therapies, particularly therapies that deplete the immune system, for instance, drugs that attack B cells or plasma cells, an example would be daratumumab, that may have a further decrement in response. But again, the exact implications that has for protection, we're still learning about. So let me just ask, the next step that I wanted to talk about is about cancer vaccines. We'll talk about that for 10 or 15 minutes, and then we'll stop and ensure we have time for questions. Does that sound okay?
Yes, that sounds perfect.
Okay, great. So, what we've been talking about until now is sort of saying, well, how can we train the immune system to recognize pathogens, a virus, a bacteria that's foreign? And we talked about the idea of the appeal of the immune system is that it not only can make a response for today, for this moment, but it can form memory, so that if you are immunized against the mumps and you get exposed to it 10 years later, you are protected because you already have intact T cells and cells in the immune system that have already been primed, that have already been educated. And now, once they see that pathogen again, they can re-expand and protect. And so you have two real aspects of the immune system that are, we think, very precious. One is this idea of memory, and the other is that the immune system has overlapping strategies. It's not completely based on an antibody. It's not completely based on a T cell or NK cells or other cells that are a part of this, macrophages. It has sort of this network of cells that work together. And the advantage of that is that it's harder for pathogens to outsmart it because it doesn't just protect in one way with one mechanism. So there was a lot of interest in asking, could cancer be targeted in this way? Could cancer be essentially shown to be foreign, have certain aspects that could be targeted? And could we then develop an immune therapeutic approach that not only would target those cells, but would provide a long-term protection? Now, I think there was a long period of time where people felt like that's a fantastic idea, but pie in the sky, it's not going to really work. But what we've seen recently is that it does work, or at least there are aspects of this that can be very powerful. And the question is how to do this in a thoughtful way, and in what diseases is it going to work better or worse? So just to talk, about this idea that when you're trying to target myeloma, for instance, or any cancer, what you're trying to do is, number one, tell the immune system that there are unique targets to go after. So one question is, to what extent is a myeloma cell different than a normal, let's say, immune cell, a normal antibody-making cell, plasma cell? And to what extent is it the same? Because it is in that way a harder target than if you're going after bacteria that has less sort of similarity to us as our normal cells. So part of it was defining things that are different and showing that there are targets. And we've known for a while that there are examples of proteins that are either overexpressed or strangely expressed in cancer cells, myeloma included, and that gives us a potential window or target. The other thing we know is that individual patients have mutations, and mutations are part of what drive cancer, but those mutations may also make abnormal proteins. And so the very mutations that drive cancer may actually provide an immunotherapeutic window or target that you could go after. So that's part of it, is are there targets? But the second part of it is, how do you break tolerance? Because part of what goes on with the cancer is that it is similar to us. We have mechanisms, as I described earlier, that tolerize the immune system so that it doesn't overact, it doesn't cause autoimmune problems. And cancer tends to take advantage of that as well. And one of the classic examples of that is, for instance, the PD-1 pathway, which has been shown to be regulated by cancer cells, and it helps to block immune responses. But that PD-1 pathway didn't get made up by cancer. It actually comes from our normal immune system and how it prevents attack, overexuberance. And so cancer cells kind of hijack those tolerizing mechanisms to shut off the immune system. So there may be targeted ways to turn it on. And so we know in some diseases that by just turning on or breaking that tolerance, we've seen really nice responses. And this has been seen in several solid tumors, and at least a subset of patients with things like lung cancer, kidney cancer, melanoma, and in some settings in blood cancers like Hodgkin's disease. But just breaking some of those pathways by themselves don't seem to be enough in blood cancers like myeloma. And it may be because we have to do more than just blocking those pathways. We also have to raise the number of T cells. Now, one example of that is CAR T cells. And CAR T cells are basically T cells you're taking from a patient, and you are putting into them a target that recognizes myeloma. A very common one is BCMA, a target on myeloma cells. And those cells are then turned on. So if you remember, I was saying that there's a balance between the things that turn cells on and turn cells off, that equilibrium, the tolerance versus activation. And with a CAR, what we do is we put on a permanent on switch, and then we put the T cell back into a patient, and you can see that those T cells find their targets. They get very exuberant. They can cause all kinds of negative reactions, fever, and signs of immune activation, but they can be very powerful targets of myeloma and cause high rates of response. And so you can see from those two examples, the PD-1 blockade and the CAR T cells, that the immune system actually has a bite to it and it can really target these cells. But as you can imagine, how do you make this last? So that raises this question about vaccines. And could a vaccine that targets a cell, for instance, myeloma cells, create an immune response within the patient that is more durable? Could you develop that memory response, much in the way we do against pathogens like mumps or measles? And how would you create that effect? And so people have tried to, as I mentioned with infection vaccines, do similar things. Take a piece of a tumor and introduce it with something that would stimulate the immune system and see, can that cause an immune response? Now, when they tried to do this against individual targets, individual antigens, we would often see an immune response, but it wouldn't necessarily lead to a prominent sort of clinical effect. And part of that is that you're depending on an immune system within the patient that may not work as well. So in the same way that a flu vaccine may not work as well, in the same way that that can happen, you can see that also with a anti-cancer vaccine, but maybe you don't have the tools to fully respond. So it became clear that we needed to do two things. We needed to maybe broaden our response, so not just going after one thing, and that we needed to do ways to stimulate the immune system or to break this tolerance. And so this sort of more recent generation of vaccines have tried to do that. They pick targets that would be more easily recognizable, and the mutations are one example of that. And they've tried to use systems that would more effectively generate the immune system. So I just going to talk briefly about our research, and then we'll open this up for questions. So what we've been doing is we've been taking cells of the immune system called dendritic cells. They are natural teachers of the immune system. They are loaded with the stimulatory proteins that break tolerance. So their job is, when they see a pathogen, they will present parts of that pathogen now with all that stimulatory molecules that will induce an immune response. And so we have, and others have been looking at this notion of, how do you introduce parts of a tumor into the dendritic cell so it could generate a response? And what we've been able to do is we've developed a model where we take a patient-derived tumor, in this case myeloma, and we fuse it together, or we create a mixed cell with the patient's own dendritic cells. And we've learned to grow these dendritic cells from their blood. And so the way we do this is we collect their myeloma cells from their bone marrow, and then from the peripheral blood collections, we would generate dendritic cells by growing them with a certain kind of mixture of hormones that stimulate the dendritic cell growth outside the body. And then we take those two cell populations and we put them together with something that transiently dissolves the cell membrane. So the membranes are lost, and then we dilute that out so that some membranes reform. And now you have a cell that's half dendritic cell and half tumor. And so what we hope that can then do is stimulate immune response targeting multiple different antigens at the same time, and provide that critical co-stimulation from the dendritic cell that will break tolerance and drive response. And this is something that we are now studying first in smaller studies, where we were able to show a pretty dramatic expansion of the myeloma-specific T cells and what appeared to be some improvement of response after transplant. In other words, we were vaccinating people after transplant. And now we are in the midst of doing much larger studies, including a national study asking that question. Now, this has been, one, we hope, very powerful tool that will generate an immune response. But as I think you've heard from my larger discussion, this is a complicated problem to solve. So it may be that a particular patient has the ability to mount a full response with just, let's say, the vaccine, or you might need a strategy that incorporates a couple of different approaches. One that may stimulate the immune system in certain ways, one that may provide T cells that are more activated outside the body, one that involves blockade of the checkpoints now that you're providing those T cells. So there, you can see that there may be different ways to reconstitute the immune system that may not all be about just one intervention that allows you to expand these cells, activate them, and then keep them going for the longer term. So I think all of those different components, and they include things like CAR T cells and the immune regulatory agents and the T cell engagers and the vaccines, are going to be brought together in different ways in different patients to understand what are the necessary elements to drive a long-term response. Now, one of the things that's happened is we become much more sophisticated in understanding the immune system of each individual patient. And we can do things like what we call single cell transcriptomics, where we look at each T cell in a patient, we look at its programming, we understand it's to the most molecular genomic level, and we'd say, this patient has a predominance of a certain kind of pattern of T cells, while this other patient has a different pattern. And so on one hand, you have to have therapies that are broadly applicable. On the other hand, there may be differences in the population there that would need different things. And so there's a lot of effort now, not just in developing therapies, but understanding which part of the population is going to better respond to different types, or which type of patient may need two interventions versus one. And that's been a big focus right now in cell therapy in general and immune therapy in myeloma in a more specific way, where there's a lot of attention to that. So I think it's a long time to talk. So let me stop now and see what questions people have.
Great, and I'll moderate those questions just to make it a little bit easier for you. Let me start by asking you the stage of these vaccines. Is it still in clinical trials? When do we see approval coming? If you could just speak to that.
Yeah, I know, of course, that's a very important question. So I think, as everybody knows, there is a process of trials that are done to assess how well something works and what are its side effects and whether the risk-benefit ratio, is good, and that it should go part of the standard of care, but also what are the right patient population that would benefit. So, I can speak specifically about our vaccine, but there are other ones out there that are being studied. I think the initial studies around safety were in general reassuring, although we're always still learning. The phase 2 studies of looking at what are the settings where this may work the best, what's the actual benefit, how does that sort of correlate with then balancing risk. Those are the studies that are currently ongoing right now. And I think the very fundamental question of, are these standalone treatments? Are these ways to amplify responses? As an example, one question might be, CAR T cells have a very powerful response, but most patients, they're temporary. Is this a way to make that a more durable response? That's something that we're looking at. So I think the answer is we're still in that phase of defining the percent of patients that seem to respond, what immune system that correlates with, and how might these be in standalone versus combination therapies. So they are not at this moment approved, but they are part of this larger conversation of what's going to be the right immune therapy for this disease.
Perfect. Thank you. It's an exciting conversation too. Just I don't know, kind of how you were saying earlier, it seems like a pie in the sky thing, but now it's becoming reality. And so this kind of progress is super exciting. And your whole discussion was super intriguing to me. I learned quite a bit. So thank you for what you've shared so far. We have some questions. I see several questions about when to delay treatment. When is it appropriate to delay treatment when getting the COVID vaccine? I've heard differing opinions, so we'd love to hear yours.
Yeah, I think the reason you're hearing differing opinions is that we don't know all the answers to these questions. So people can give you their thoughts or their ideas. And sometimes that's what you have to rely on, because there isn't going to be an exact study to tell you about every situation. I think that there are a couple of concerns when one thinks about how do you integrate COVID vaccination with ongoing treatment. One of those concerns is, will the effectiveness be compromised if you, for instance, are somebody who's on a high dose of steroids for whatever condition? I mean, myeloma may involve steroid therapy, but there are, of course, autoimmune diseases and other things. You can imagine that giving somebody a vaccine and a big dose of high dose steroids the same day intuitively feels like that you'd be kind of shooting yourself in the foot, and that you probably wouldn't make a good response to that. So then the question is, well, how much can we understand about individual myeloma therapies, and can we integrate a good strategy for that? So there are therapies that we think are more immune suppressive and ones that are less. And certainly steroids are an example of something that suppresses the immune system, but so do things like proteasome inhibitors like Velcade, and antibodies that target things like CD38 like daratumab, or BCMA like belantamab. I think those drugs probably do suppress the immune system. It's a fair thing to say that we don't exactly know for an individual person what they will do to their response. So we, in patients where the disease is quiet and there's, not a lot of pressure, we often have the luxury to say, you know what, there's not much going on with your disease at this moment. I don't want you to take too much time off, but let's give you a couple weeks, get your vaccines, and get through that, and then we'll kind of rethink about where we're at. I mean, there is, of course, the concern that if, let's say, you did that and the person had a nice response, that when you then restart their treatment, you could affect their response. In other words, it's not that that window disappears, but it would at least make intuitive sense. And what I'm describing here is intuition, because it's not like there's regulated studies that have answered all these questions. On the other hand, if somebody has a more aggressive disease, that holding treatment really has negative consequences. And this idea that, well, the vaccine is, you need a period, but we don't know how long, you can do damage by starting a long period of holding treatment, and then the disease starts to grow. So those are the things we weigh, but of course they have to be very individualized. The other question is, would the side effects of the vaccine or of the treatment somehow interact with each other? We know that the vaccine can affect things like blood counts. It can affect the immune system in ways. And thankfully, if you look at large numbers, the benefit of the vaccine, far outweighs any of those risks. But, there are risks nonetheless. You have to think about it, think about individual situations. So there are drugs that we use, for instance, like lenalidomide or pomalidomide, that we think have at least an immune stimulatory component. Would they help vaccine response? Would they potentially interact with toxicity? We don't know. I think those are more likely ones that we often are feeling less nervous about holding, at least from the point of view of suppressing the response. But I think you can tell from my discussion that we are using our best logic with individual patients based also on the pressure of what's going on with their disease, rather than we have definitive understanding of this. There's been some discussion about what to do with transplant patients. And this was, when the vaccine first came out and people were very anxious to just get going, we often would vaccinate anybody who was out after, let's say, a few weeks from their transplant. There's probably some evidence that you wait a little longer, you get a better response. So there's probably, the recommendations are probably to wait more like 3 months. But, if you read those recommendations, they'll say, unless you're really worried in the here and now, then try it now. I don't think that protection is all or nothing. In other words, we know that patients may have a low level of antibody, or they may have a T cell response that we don't even measure, that is not perfect and is not perfectly protective, but better than nothing, or maybe offers some protection. So I think there's a balance here of timing that has to do also with those concerns and where the pandemic is in a particular geography.
Okay, yeah, it's multifaceted then. It sounds like there's a lot of considerations to take account. Can you provide some practical advice for myeloma patients? It's kind of a scary time, still with COVID, and then with this Delta variant. Of course, wearing the masks, hand washings, avoiding crowds, this person says is obvious. But should we work if we wear masks, and should they fly and self-quarantine? The question mainly is that N95 mask, is that enough? What's your professional opinion?
Yeah, I mean, these are, of course, vital, important questions that we are really working together to try and understand and figure out and give guidance. And there is an element here of risk reduction. There is an element, of course, of personal choice, and how to think about that. So I think that the original idea is, well, when you're vaccinated, you're all set. I mean, I'm not saying that anybody totally thought that necessarily, but there was certainly a thought
I
that
kind of did. I wished.
yeah. So, and I think there is, of course, reality to a person who is vaccinated, at least from our current knowledge base, that there is a fairly high degree of protection, that we know that infections are still possible, but they tend to be less severe, and the chances of having life-threatening complications of COVID are much lower. They're not zero, but they're definitely lower. Is that exact equation going to be true 6 months from now as it is today? I don't totally know, but that's what we are seeing, and it's not a subtle difference. It's quite a giant difference, but it doesn't totally prevent infection. Now, what about a person whose immune system isn't perfect or who didn't make a great antibody response? Is that same principle true? And I think, as you might imagine, we don't know, but we think it's probably somewhere in the middle. There's probably some benefit, but we can't assume that. So we kind of always told our patients, it's the same speech we would tell people after they got the flu vaccine, which was, it probably helps somewhat. We can't assume it's going to 100% work. It's important that your family members are vaccinated against the flu, because that's a way that you can get exposed. So it's kind of the same thing in that way from COVID, that we think that if you are surrounded by vaccinated people and you have been vaccinated, albeit maybe with less of a response, that you are somewhat protected. And, that was definitely a mode, particularly when the level of virus was low, that did give us the encouragement for people when they got together in smaller groups with vaccinated people to be okay with that. And certainly grandparents getting together with their grandchildren, all those important things. I think right now we are in a period that's a little bit in flux, and we're trying to understand it. So what I do advise my patients right now is that they certainly, as you said, should mask in crowds, should maintain social distancing, particularly indoors, that they should assume that just because there's a large group of people, maybe some of them or even all of them are vaccinated, we don't exactly know what's going on, and so that better to keep protection. Now, do we go back to not seeing our grandchildren in small numbers? And I think that there are risks there, but there's a little bit of individual decision making about how to approach that. But I think in general, it is true to say that we should assume that people have to be protected in ways that are a little bit more rigorous than, particularly if there's a lot of virus in that community. That's how I would advise folks.
Great, thank you. You talked a little bit about this in your last response, but can you comment more on the results of semi-quantitative antibody test results?
Yeah, I mean, so there's been some studies looking at the experience in myeloma patients as a specific cohort. There's been some in cancer patients, for instance, in a larger cohort where myeloma may be part of it. There was a recent study that focused very much on patients with CLL, which is a different disease, but it has some similarities to myeloma. It's a cancer of the immune system that has associated risk of infection with it. And there's no question that if you look at the height of the antibody response, it's lower in patients with active disease than not. Now, when you look at the spectrum, you might have patients who are in remission versus not in remission, patients on treatment versus not on treatment. And you quickly learn that it's not all the same thing, and that, as you might imagine, patients with more advanced disease or on more intensive therapy tend to have a lower response than patients who are in a relatively quiet period of their disease. Now, obviously, a very fundamental question is, well, what level of response is enough? It wasn't like everybody had zero response, it was lower. And is that antibody response a perfect window to even know who's protected? Or, as I mentioned, is it a different part of the immune system? A T cell response that's part of that also, which isn't measured as easily. I don't know, but I think that we can make the general point that the degree of protection was lower and did seem to be more impacted by certain treatments.
Okay, thank you. There's a couple more questions about the vaccine, and I know that there's a lot that we don't know about this COVID vaccine, but Do you think that it could affect the results of our post-transplant tests like bone marrow biopsies or CT body scans?
Meaning if there's an infection, a COVID infection, or the vaccine you're asking?
The vaccine itself.
I don't think so. I mean,
Okay.
it's certainly true that if you're just looking at immunoglobulin levels, let's say IgG levels, not the M protein, but just how much antibody somebody's making, we sometimes see that when patients have an acute infection, I don't mean specifically COVID, or maybe they have an inflammatory thing, maybe that number goes up a little bit, but it shouldn't really affect the M protein and certainly shouldn't affect things like the scans or the bone lesions and things like that.
Okay. And then a follow-up question to that from the same person, is it best to have the COVID vaccine before beginning chemo again after transplant or to continue to wait?
To continue to wait in terms of the vaccine or the treatment, I
The
guess.
the vaccine.
Yeah.
Like, is it because we kind of talked about if you get the vaccine before the chemo, does the chemo kind of wipe out the positive effects
Right.
of the
Right.
vaccine?
Yeah. I mean, what I would say is that, and again, this is a very individualized thing because um, there are patients where the treatment is really of vital importance and that waiting has a real downside, and that by somehow trying to optimize a COVID vaccine response, you can really create injury because the disease is not controlled. And so I think that you have to be very careful here about being like, this is a really specific, what's that person's situation, thinking about it carefully with their physician and weighing everything. I think in a more abstract way, you might say, well, if somebody has a little bit of a window to get the vaccine and make a response, will that just get lost if you treat them? Well, we know in general that if patients are vaccinated against a lot of different things, not just COVID, that they don't lose all their vaccine response right away the minute they get any kind of treatment. So it may be that if you establish a response, there is some longevity to that. And for instance, the one way to think about that is when you're actively making your response and then you hit it with an immune suppressive therapy, maybe that affects that. But if the response has already been established and those cells are there, they may be less susceptible to the moment-to-moment treatments that person's getting. So that's at least the logic of not simultaneously doing everything. But how long you would wait is very individualized, and whether you should wait at all and which comes first, I think these are really hard discussions and decisions. And they may not even be like there's a single right answer to them, but they have to be just really individually thought about.
Okay, I think that's a great answer. Thank you. Some people are asking, do you recommend a third or alternative COVID vaccine if they have stable myeloma?
Right. So, I mean, this is something that I think as a community, we're going to hopefully find out in the next couple of weeks, maybe, or a month or two, what the federal government, what the CDC has to say about this. I think that in Israel, for instance, they've started with a third vaccine, I think a week or so ago. And that was based on the premise that they were seeing some evidence of, of course, increase in infections probably related to a subset that was relatively smaller there of unvaccinated folks. But then, people who've been vaccinated, but have vaccinated a while ago being susceptible. And they were able to show in some studies that there was an amplification of the response with that third booster. And, we have certain vaccines like hepatitis where we routinely give 3, that if you give 1, you see low responses, 2 a little bit, and it's the third that you really get the final kick. And so maybe we'll find out that that third vaccine makes all the difference. That would be great. In immune compromised patients, there was a small study of solid organ recipients, meaning things like kidney or liver transplants. And those patients did show that after they got the third vaccine, they really did have a better response than after just 2. And that laid clearly groundwork for people thinking, well, then I want my third vaccine. Obviously the simple question is, what are the side effects of the third vaccine? What's the benefit? My guess, and that's just what it is that there will probably be turning towards that direction. All of us are in this country looking towards federal agency to tell us, what's approved, what's the plan. We don't have the prerogative to do that individually. So my guess is that we'll be learning more about that in the coming weeks. And it may be that the experience in Israel provides some help for the rest of the world
Right.
also to kind of see what the experience is.
Awesome. Thank you so much. Another question. Her husband was vaccinated before his stem cell transplant. Now he's about to have his stem cell transplant. Do you think he should be vaccinated again post-transplant?
Yeah. These are all great questions. Of course, I don't have a definitive answer. What I can say is that in general, if you say, how do people do with vaccine immunity after transplant? Forget about COVID for a second,
Mm-hmm.
because there we do have a database. We know two things. One is that there was at least a study that seemed to suggest that pre-transplant vaccination, so remember the way a transplant works is that we collect stem cells and then give it back to a person. So those stem cells, if they saw the vaccine, they potentially could transfer back some level of immunity post-transplant. So that would be the logic of pre-transplant vaccination. And there have been some studies where they said, well, what if we gave people certain vaccines pre-transplant and then boosted them post? And they said, oh yeah, that's actually better than if you didn't give it pre. So there may be some retention of response. There's certainly a substrate to build on. But, is that going to ultimately have enough protection to it? And what was their response pre-transplant, and what
Right.
else was going on with them, and what other treatments were going on at the same time? All that is going to be an individual story.
Okay. And then she was also asking, is it unreasonable to only allow vaccinated people into their home? And I would, just my personal opinion, I would say I don't think that's unreasonable, especially since we've been talking about you want your close community around you to be as protected as
Let me just put it this way. I don't sort of hang out with unvaccinated people
possible.
indoors. So I would tell my patients very definitively that's a no. This is where it gets hard with particularly young kids or family members,
Right.
and it's easy to say that if you don't have, kids in that setting, but I know that's harder. But
Mhm.
let's leave that harder part out for a second. I think in general, anybody with myeloma who hopefully has some level of protection, they still should not be hanging out with unvaccinated people indoors. And what we're now trying to understand is, what does that mean for vaccinated people in terms of their ability to transmit? And so
Yeah.
I think I don't have all the answers to that one. I think a lot of us are trying to figure this out in real time. But I agree with you. For unvaccinated people, particularly people who are not part of that person's immediate circle, I would not be spending time indoors unmasked.
Thank you. We have a couple people asking if you can recommend any research or resources that could be used to help convince their friends and family members to be vaccinated, um, since they run into that problem quite frequently.
Yeah, this is one of those topics that gets people going, including me. And I think, all of us know that the best way to reach people is probably not to shame them or
Mhm.
to make them feel stupid or kind of embarrass them. But the behavior can be infuriating. And people might say, well, it's my body, but I don't get to say, I just happen to like drinking and driving. Why who are you to tell me I can't do that? We live in a society where our actions actually do affect each other. So there are rules, and this is a way that people make themselves dangerous to other people. So I think the probably best strategy is persistence and putting things in terms of settings that they're going to listen to and understand, and not try and like berate or,
Mhm.
but it's hard. I don't, I did find that when you tell people things like, I'm not sure how much we have of the vaccine and we hope we can get you some, that people are like, well, you better make sure that I get some. And if you say, we really want you to take the vaccine, people are like, well, I don't know about that. So I think there's all kinds of psychology to this, but I don't have any wisdom other than what I'm sure people can think on their own about how to reach people. It's really frustrating.
Thank you. My last question would be, in regards to the stem cell transplants, when they start receiving their vaccines, what side effects should they be looking out for? When is it appropriate to come back to the doctor and say, I don't know if my body's doing too well with this vaccine?
Yeah. I
Um,
mean, I think, part of what I was trying to give in terms of giving the background and the scientific kind of understanding of this whole equilibrium between tolerance and activation it gives you, of course, insight into side effects. So we know that a very common effect from a vaccine is that people, for instance, might get fever, or they might feel achy, or they might feel like they have, flu-like symptoms. And that's in some ways exactly what the immune system does. That's the reason you feel that when you have the flu is not because of the flu, it's because that's what your immune system does when it sees the flu. So I think that those kind of reactions are very typical and not necessarily worrisome. Of course, if somebody gets a fever and they also have a low white count or they have a suppressed immune system, we might blame it on the vaccine, but we still want you to call your doctor and we still
yeah,
want to hear about it. I think the more significant complications, the autoimmune complications after a vaccine, which are rarer and thankfully also usually transient, may have to do with things that are more fundamental about the immune system, a rash, breathing issues, things that have to do with the organ function. We know that inflammation around the heart was one of the things that they saw, for instance, after COVID vaccination in a pretty small subset of teenagers. Honestly, I think those were pretty much all very transient, went away. It just shows that the immune system has become activated. So, I mean, our general experience to the patients is to just, if you're not sure, just call. And hopefully it can be something that we can be reassuring about, but people shouldn't sit home with funny symptoms and wonder whether I should call.
yeah, always be safe. I'm sorry. Well, wonderful. That was fascinating. Thank you so much for your presentation, and we really appreciate you taking the time with us today. I'm
Sure.
just going to finish with a couple of outro announcements, and then we will be done for the day. Um, so if you want to join us next month in our stem cell transplant chapter, we'll be hearing from multiple myeloma journey partner Michael Riotto as he shares his experience of getting an infection during his stem cell transplant, what recovery was like for him, and how to move on to make a full recovery even when things don't go as expected during your stem cell transplant. I think it's important to talk about the reality of the experience and what potentially might or could go wrong, even though we hope it doesn't. We may be interested in other myeloma crowd community events coming up. Tonight we have the launch of our minimal residual disease chapter. We have Dr. Natalie Collender from UW Health coming to speak to us. So don't miss the chance to learn about this ultra-sensitive test that provides a true measure of your myeloma. On the 12th at 7 p.m. is our myeloma caregiver chapter. Author Raina Weiner will speak to us about how to trust our doctor, but not that much. We need to learn how to properly advocate for ourselves and our loved ones in the healthcare world. No offense, Dr. Avigan. On the 13th of August
Good
at
advice.
at 10:30 a.m. is our Mountain West myeloma chapter event. This event is primarily for people in the regions of Nevada, Utah, Idaho, Wyoming, Colorado, and Montana, but it is about navigating neuropathy with Dr. Kelsey Burrell, who's a neurologist. So I can't remember what kind of doctor she is, but you're more than welcome to come if that topic interests you, since I know neuropathy is an ailing side effect for quite a bit of myeloma patients. On Wednesday, August 18th at 3 p.m. Eastern, the Myeloma Coach Program Director, Rosalind Height, will be joining us to discuss the Myeloma Coach Program. She will explain how the program is helping around the nation and even the world to improve myeloma experiences everywhere and what we can do to exponentially grow this program to further myeloma research. The link to sign up for any of those events and even more events I have not mentioned today is found at the bottom of this slide and will be sent out in the follow-up email within 48 hours of this event. Its conclusion, excuse me. And then once again, a thank you to our sponsors, Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnology, Sanofi, Oncopeptides, Karyopharm Therapeutics, and Takeda Oncology. And thank you to each of you for joining us and helping us build a strong myeloma crowd community. We'll see you next month. I appreciate you and hope that you have a great rest of your day. Thank you. And thank you again, Dr. Alman.